Hello, I'm John Foster, and I'm a medical doctor who does Social Security disability exams. And today I'm going to talk about the most common problem seen in disability exams, namely spinal problems, that can often be difficult and vexing for me to evaluate. I'm going to give you some tips on how to evaluate patients with spinal pain or other spinal symptoms. As usual, everything I say is based on my own opinions, based on my own study and experience, and does not represent the opinions of the Social Security Administration or any other medical body. Now, disorders of the spine are the number one complaint patients have in disability exams. Predominantly low back pain, but almost as frequently neck pain and neck problems as well. And I think there are three confounding issues. The first is we have no accurate method of determining if a patient's experiencing pain, and if they are experiencing pain, how severe it is. If someone would invent an accurate pain meter, they would qualify, in my opinion, for the Nobel Prize in Medicine. I think the pain scale is worthless. The day I stopped using it was the day I was handed a chart showing that a patient was complaining of 10 out of 10 pain in 6 different areas, and I walked into the exam room to find the patient reclining on the exam table in a state of supreme ataraxy, eating Popeye's chicken. The second issue is the dreadful state of radiology in North America. In my experience, 99% of spinal MRIs are read as abnormal, which is absurd. Imagine if a radiologist read 99% of chest x-rays as abnormal. They'd be tarred and feathered and run out of town on a rail. If there's a finding in 99% of the population, that is a normal finding, not an abnormal finding. It will be a great day in the United States when radiologists accept that. As everybody knows, but often refuses to admit, there is almost no correlation between reported abnormalities on MRIs of the spine and patients' symptoms and signs. And there are a tremendous number of totally asymptomatic patients whose MRIs are read as abnormal. The third confounding variable is, unlike most other conditions, patients are often educated by their physicians as to the complaints they should voice to convince a physician they have severe spinal problems. If I had a nickel for every patient who told me that their spinal pain radiated, I could build a lovely house out of nickels. Those patients didn't come up with the term radiating by themselves. They were taught that by a physician. So as we always do in medicine, I'm going to start with the history. I think it's very important to ask open-ended, non-guided questions of patients with spinal complaints. Don't ask them, does the pain radiate down your legs? You're teaching them what the proper answer is to qualify for disability. Instead, ask questions like, what is the pain like? Does it go anywhere? Does anything make it better or worse? And do you have any other symptoms besides pain? Always keep in mind that in most cases of spinal problems with radicular symptoms, it's due to posterolateral herniation of a spinal disc. And in that situation, the symptoms should be unilateral in one arm or leg. I find that a great number of patients who are either fabricating their complaints or exaggerating their complaints will say that they have weakness in both arms or both legs, and numbness in both arms and both legs, and that the numbness is in a stocking glove distribution rather than a radicular distribution. If the patient tells me that their pain is radiating, I ask them to explain what they mean by that. We've all had radiating neurogenic pain because we've all hit our funny bone at one time or another. And as you know, when you hit your funny bone, it causes pain, tingling, and numbness distal to the injury and in part of the forearm and hand, not the entire forearm and hand. Cervical root compression and lumbar root compression present in exactly the same way. To make matters more difficult, a minority, but a substantial minority, of disc herniations are central, and that can produce bilateral symptoms. In the neck, it will tend to cause cervical myelopathy, and in the low back, lumbar myelopathy or cauda equina syndrome, and it's important to always be on the lookout for those problems. Next, I'm going to go to the physical exam, and I think it's very important to observe the patient walking into the exam room, sitting down in the chair to give the history, and then rising from the chair and walking to the exam table. Sitting down in a controlled fashion and rising from the chair involve extension of the hips and the knees, and thus require adequate strength of the gluteal muscles and the quadriceps muscles. If the patient exhibits normal walking, normal sitting down, and normal rising from the chair, and then demonstrates severe 4 out of 5 or even 3 out of 5 weakness of the legs on physical exam, something is not right. It's either functional weakness or exaggerated weakness. The next clue in the physical exam comes with palpation of the spine. Always keep in mind that the structures of the spine are deep structures. They're underneath the skin, the subcutaneous tissue and fat, fascia, and muscle. Lightly brushing the hands over the skin of the neck or back will not exacerbate neck or back pain. If the patient acts as if light touch is agonizing, they're either fabricating or exaggerating. Another useful test for lumbar problems is axial compression of the skeleton. What you do is place both hands on the vertex of the skull and press down hard. Try it yourself. Put your hands on your head and press down as hard as you can. You'll find that your neck will become uncomfortable. However, none of the force is transmitted to the lumbar spine. It's all absorbed by the cervical spine. So if the patient complains of agonizing low back pain with axial compression of the skeleton, again, it's fabrication. Next, you want to look for neurological signs, and first I check sensation in the arms and legs. Always remember, if the patient has a radicular problem, they will not have numbness of an entire arm or an entire leg. It will be partial in the distribution of the nerve root. Keep in mind my do it again sign, which is you apply a stimulus to the patient's arm or leg and ask them if it felt normal, and they say do it again and look at you quizzically. I have found this 100% accurate in diagnosing a functional problem. If the patient really has physical numbness, it's obvious to them and they don't need you to try multiple times. Again, think about the time you hit your funny bone. It was obvious where your arm and hand were numb. You didn't have to test it multiple times. Likewise, if the problem appears to be compression of a cervical or lumbar nerve root, there should be isolated motor weakness in the arm or leg corresponding to the muscles innervated by that nerve root, not universal weakness of an arm or leg. And lastly, I always check reflexes, and I find them very helpful. It's possible for patients to feign many of the signs of problems with the cervical and lumbar spine, but it's impossible to feign abnormal reflexes, and here's why. Reflexes go from the sensory nerve in the muscle to the spinal cord and then to the motor nerve in the spinal cord, and the reflex is complete before the brain is even aware of the hammer striking the tendon. Now I see a lot of patients who feign abnormal reflexes. What they usually do is jerk their whole body when I tap on their patellar tendon. However, this jerk is slower than a real tendon reflex because the nervous impulse has to go from the muscle all the way up to the cerebrum and then back down from the cerebrum to the motor nerve. It's impossible to fake a real deep tendon reflex. Real abnormal deep tendon reflexes, to me, are very strong evidence that the patient has an organic problem. Two more fairly rare signs that definitely point towards an organic problem are muscle atrophy, characteristic of lower motor neuron lesions with denervated muscle, and fasciculations, also characteristic of lower motor neuron lesion with denervated muscle. If the patient has muscle atrophy and or fasciculations, you can be almost 100% certain that they have serious neurological impairment. Now, a real confounding variable can be the presence of cervical myelopathy, which can have no neck pain whatsoever. And keep in mind, cervical myelopathy may be caused by cervical stenosis, and 20% of patients with lumbar stenosis have a concomitant cervical stenosis. Cervical stenosis tends to present with lower motor neuron signs at the site of the stenosis or lesion, and upper motor neuron signs below the site of the lesion or cervical cord compression. And if you have concomitant cervical myelopathy and lumbar myelopathy, you can get a very confusing picture of both upper motor neuron and lower motor neuron signs in the legs. Characteristics of cervical myelopathy are trouble with fine motor skills in the hands and difficulty with walking with a broad-based, somewhat ataxic gait. When checking for upper motor neuron signs, I find it very helpful to test the Hoffman's test and the Babinski's test. I've never met a patient aside from the physicians I've treated who knew what the abnormal response was to these tests, and a positive Hoffman sign or Babinski sign, again, is almost pathognomonic of an organic structural neurological problem. So to summarize, observe the patient very carefully as they enter the room, sit down, rise from their chair, and sit down on the exam table. Ask open-ended questions. Don't suggest the answers. And look for signs that are impossible to fabricate. The final sign that I find very useful, I've never found mentioned in the literature, so I'm going to call it the Foster sign. This is when the patient is supine on the exam table and they're complaining of low back pain. See how the patient gets up when you ask them to rise from the supine position and stand up. I've had some back problems myself, and I quickly learned that sitting up straight, like doing an abdominal crunch or a sit-up, really made the pain worse. You're applying tremendous pressure to the lumbar discs when you do a sit-up or abdominal crunch. It's far more comfortable to roll on one side first and then sit up sideways. If I see a patient complaining of severe lumbar pain with lumbar tenderness and other symptoms and signs, and I ask them to sit up from the supine position, and they sit up like they were doing an abdominal crunch briskly with no distress whatsoever. I'm always very suspicious that their complaints are functional or exaggerated. On the flip side, if I see them first roll over on their side and then lever themselves up sideways, I consider that very strong evidence that their low back pain is organic or physical in origin. Well, I hope this has been helpful, and always keep in mind, if it happens, it's possible.